Hello, fellow caregivers out there, or anyone else who is just trying to learn and is not a caregiver yet, but might be a caregiver. Hello to you. Welcome to this podcast. I'm here with David Cook with the Alzheimer's Association Arkansas chapter. Many of you who've been following this podcast, he's been on several times through the years, and primarily he's the go-to guy. He's the guy that I always say is boots on the ground at the Capitol, talking to legislators, congressmen, senators, anyone who will listen, trying to get more funding, trying to get bills passed, trying to get people to understand the importance of some of these drugs that could be of help to others as they begin their journey of slowing it down. And so we have some good news. So we're going to talk about a new medication that was passed, right? Okay, good. And then we're going to talk about some other things in the pike, positive things that you've been working on and learning about. So welcome, David.
Well, Theba, thank you for having me. It's always a joy to be on here and appreciate the opportunity to talk more about our work and what we're learning about developments and research and some of the hope that we see, particularly as you think about treatment. So I'm looking forward to the conversation today.
Well, what is this good news? We saw it all over the news, so I'm sure you guys are getting calls. I know Carolyn yesterday when I was talking with her with the Alzheimer's Arkansas, they've been getting calls because whenever anyone out there who's dealing with a loved one that has Alzheimer's or they're seeing some cognitive memory impairment from by a loved one, or maybe they keep their ears glued to the possibility of having a drug. Tell us about this drug.
Sure. So just a couple weeks ago, as the news has been reporting pretty much across the country, we learned that the FDA finally gave traditional approval to a drug called lecanemab, but it's also called Leqembi, which is much easier to say. But this is very exciting and brings hope to individuals in the early stages of mild cognitive impairment. And what's exciting about this drug and this is actually we received FDA approval, but this is the first time in over 2 decades that we've had an Alzheimer's specific drug that treats some of the hallmarks of the disease. Previously, all we've had were drugs that people see, like Prevagen and things like that on the market, that are only there to treat some of the symptoms that accompany Alzheimer's disease. With Leqembi and other drugs in its class, what this drug does specifically is slow down the progression of the disease. When someone is diagnosed with Alzheimer's, one of the hallmarks that we notice is they get these things called, or this protein called amyloid plaque that builds up in the brain. And so what Leqembi does and other drugs in the MAB class is it's what we classify as an anti-amyloid drug. And in this first generation of treatments, that's where most of the research is showing promise, is being able to actually reduce the buildup of amyloid plaque, which allows the disease to progress. And what Leqembi has shown is that it's able to delay progression of amyloid plaque and the buildup, and in some cases, it's actually able to reduce amyloid plaque and erase some of the protein. At the 18-month mark, it showed that it had slowed progression in over 40% of the patients, and especially just very minimal side effects for individuals who do not have other chronic conditions like diabetes or hypertension that complex. Like with any drug, there are some side effects, right? But in this first generation of drugs, again, there's a lot of focus on trying to reduce the buildup of that amyloid plaque. And so behind lecanemab, there are other drugs in the MAB class that is targeting amyloid plaque that have also shown some promise as well. So we know that Leqembi performed very well in the clinical trials, and now that it's out on the market, it it is giving people hope and the promise of more time with their families, the more time to be able to engage in activities, to watch people get married, to watch grandkids graduate from college. And so these anti-amyloid drugs do just that. They give people more time and can slow the progression of a very aggressive disease, as you're well familiar. But Leqembi is not the only drug that's shown promise. We are on the heels of the Alzheimer's Association's International Research Conference. So last week, thousands of researchers from across the globe gathered in the Netherlands to discuss some of the developments and report some of the findings that they've seen in their individual research. AAIC is the largest research conference in the world, and so we sponsor it, or we host it in an international site one year, and the next year we bring it back to a domestic here in the U.S. And so this year it was in the Netherlands, and there was so many developments that came out for the research just from last week. So it's fresh off the presses. Some things we're still learning that show a lot of promise and things that we see in development that are very encouraging.
Now, on this drug, is it something that someone has to catch at the very beginning of cognitive memory, or can it be applied at any time, any stage?
That's a great question, and what we're seeing in these early drug developments is that the only people who really qualify or benefit from these drugs is someone who's in the very early stages of mild cognitive impairment. So what does that mean? Well, for us at the association and other health organizations working in this space, it means that we need to place a higher priority on early detection and diagnosis, and how essential it is for individuals to start those conversations, as you have with their providers, very early on, so that you can establish a baseline so your physician has treatment options down the road. What we do know about these drugs is that every day about 2,000 Americans age out of eligibility for these drugs, so access to the drugs is going to be important. And then as we look forward in our work, early detection and diagnosis and access to diagnostic tools is also going to be important. And so this is, it's very exciting for individuals that it benefits, but we're in the early stages and we're starting to uncover how complex those access issues are. And so we're starting to see some of that in the state. We are closely monitoring here in Arkansas which physicians are actually going to prescribe the medicine. So there's a lot for us to still learn as this treatment begins to gain more traction and people get access to it.
So right now, this is July 27th, 2023. Did I say that right? Goodness. All right. It's not yet at a doctor's office, right?
We don't know any physician in the state of Arkansas that has prescribed it yet at this date. And so we heard from UAMS yesterday that they do not have access to the drug, and they also do not know of any physician who's prescribed it yet. But we do talk to clinicians in the working in the space, some different gerontologists who share our excitement about having access to a treatment, which will change the way they practice in terms of having conversations with their patients, and for the first time they have actually a viable treatment option, which before we could only treat the symptoms, right? So when you have these treatments, we've actually seen this happen in other spaces. Cancer is one that we always look to because they went through the same thing we're doing in the Alzheimer's community. They had that moment where they had a treatment for a particular type of cancer and the excitement about that. So that develops new testing models of how we test for this type of cancer now that we have a treatment model. And I think the same thing will happen in the Alzheimer's space. We'll talk about early detection and diagnosis. Now we have access to a treatment. And I think I want to reiterate that lecanemab is not the only drug. Well, there are other drugs in the pipeline that are coming who that's performed really well in the clinical trials that we're looking for FDA approval for. And so when those things become more widely available, that's going to just change the market in terms of motivating more research around how do we detect it early, how do we get people qualified for this drug, how do we get access to the drug. And so it's more complex than just saying, hey, we've got a treatment,
Yeah.
This is going to fix everything. There's a lot of other moving parts we have to kind of decipher and work through.
Oof. Well, I know that my email was kind of blowing up with information about that, and I know that other people have tried to tell me about it. So people were really kind of jumping on because it just seemed hopeful, like the first time something was talked about as being. Because it's, hey, I've been hanging out with you for a couple years, and there's, like you said, there are other drugs that have tried to get on board, and it's just so hard to do, the approval process. So it's, I know it's frustrating to you, and I know it's frustrating, obviously, for the community of people who are dealing with Alzheimer's.
It is frustrating when things don't progress as quickly as you'd like. But at the same time, it's also a very exciting time in our space because we can give people what we've been wanting to give people for a long time, and that's hope for more time. And so now we've got that. We need to celebrate that, and we also need to celebrate the other treatments in the pipeline because it means we're getting closer to understanding more about the disease. And now that we're able to actually produce a viable treatment, that's certainly exciting.
So, David, before the tornado came through on March 31st, you had issued me a challenge, and I haven't had a chance to talk to you about it. And we talked about it, I think, during our last podcast about how important it is if, my dad had dementia Alzheimer's, dementia Lewy body, and he passed away in 2019. And, of course, now my mom has Alzheimer's. So my brother and I are always thinking, whew, is that our future? And so it's a very scary proposition when you're encouraged to begin the conversation. Now, I was more I'll be 59 in September, but I've always been a proactive individual. So I decided to go ahead and hire, I guess that's the right word, my dad's doctor and my mom's doctor, who is a longevity doctor who specializes in aging and has a lot of skills regarding this disease and training and just experience. So I decided I wanted to go ahead. So that was my first step. It's like, I know I'm just going to be 59, but I want to begin to talk with a doctor about my aging process. And then she obviously knows about my parents, and as she's treating my mom right now. So you encouraged me the next time I talk to her to say, hey, I just want to begin the process of maybe doing some cognitive memory testing. And so that's the next step, right? Just have the conversation. So, right. And it's nerve-wracking because, so we had our appointment set up, and I kept it, even though because we were kind of out of all the tornado repair and recovery, the extensiveness of it. And so I kept the appointment, wanted to be brave. So that would be my third step. And so we did not do a test, but I was willing. We talked about how I was feeling, especially since the tornado and all of that. And so I think her goal was just to have a lengthy conversation with me about what I thought, how I was doing. I think she could tell that all the different things that I handled during the tornado, financing, repair people, etc., gave her encouragement. So we will talk again about the next time. So I think that was her way of just kind of having a conversation with me, going through all these different facts of what I handled, and going, okay, I think you're. I didn't hear any concern. That's what I felt like she was saying without saying it, and I ended it, and I said, okay, so whenever you feel like, if I come back to you in 6 months or a year from now for my annual and I have some concerns, we can do cognitive memory tests to see where I am. So I share that because I've always, my friends in the field of this disease are encouraging me, and then I'm sitting here on my podcast and encouraging others. And so I need to be that type of person who's actually following through. So let's talk a little bit about your experience with that, of encouraging people and why that is important, especially now that there's this drug is on the horizon.
Yeah, that's a good point. one of the things that we ran a survey 2 years ago with the health department, and one of the questions we asked individuals is whether or not they were experiencing any changes in memory that impacted their daily living. And, we had quite a few people who said, yeah, I have. And I apologize, I don't have the right statistic, but over 60% of respondents said, yes, they have experienced challenges to memory. And then you ask the follow-up question of those of you who had experienced changes in memory, how many of you have actually talked to a physician about those changes? And overwhelmingly, nearly 55% of respondents said they had not had a conversation with their physician. And so that's concerning for us at the association for two reasons. We've done some clinical data to help us understand that physicians are not actually having the conversation; they're not initiating the conversation, and there's multiple reasons why. But also people are not feeling safe enough or comfortable enough to do what you did, and that is start the conversation. And so what's happening now? I'm going to chase a little rabbit here, but one of the things I think, one of the factors we have to try to figure out is how do we shift the mindset? Because for years, when we talked about Alzheimer's or dementia, what age group did we automatically think about?
Like 80.
Oh, older people, right?
Yeah.
And so I can't tell you how many conversations I've had with people who find out what I do for a living, who may be an aging adult, who will say to me, "Oh, well, I'm glad you're doing that. We're all going to need you someday." And even though it's tongue in cheek, but at the same time, it says something about the mentality of how we think about the disease. It's just for old people, right? But we have to shift the public health mindset and start thinking about it for people my age in their mid 40s. And I've got to say mid 40s. I can't say early 40s anymore. But in your mid 40s, I mean, starting the conversation early. Again, as I told you in the previous podcast, it's important to be able to establish that baseline. But I think also for the patient, it's important to feel empowered enough to have the conversation and feel safe to have the conversation. And in our disease space, particularly, we need to work a little bit harder to try to find some strategies that can help us curb the stigma about having conversations about brain health. And so shifting the mindset to think about younger adults when we can start doing interventions. And that's where the research is, I think, leading us. Because we know that there's some certain lifestyle interventions you can do, like, healthy eating, exercise, a healthy diet, rich in fiber and protein. Those kind of things we know are good for the heart, and what we know is good for the heart is good for the brain as well. But I think one of the big obstacles people have is, again, the stigma. What if I have memory concerns? What if I have Alzheimer's? It's not a disease that we've had a treatment option for, but now that we do, and the other variable is it's got to be caught early. So we're hoping that will help, advance the conversation, between patients and their providers about, hey, memory concerns that pop up, or, when should we start having these conversations, about my brain health?
Well, and it's going to be an easier conversation for me to have with my doctor because that's what she specializes in, longevity, geriatrics. So
Right.
this is a common conversation for her. So even if I didn't bring it up, she may bring it up. So, but if you have just like a normal physician who's, looking at your arthritis or knees, you got back injury, or just treating you for this and that, but not really thinking, because that's not what they deal in daily. Don't rely on your doctor to bring it up.
Yes.
And more than likely, when you do bring it up to your doctor, if you're relatively young, and I mean not 80, because I would assume, well, let's see, if I look back, my mom's 84, she was in her late 70s, but I'm not quite sure that she didn't start having symptoms earlier than that, so, but then, of course, we know about early onset, that kind of, the early onset, people in their 40s, their 50s can start getting that plaque. So have that conversation. Now, obviously, it's going to make more sense that I have the conversation because my dad and both my mom and dad. Now, I'm not going to lie. I was nervous just having the conversation. Then I was nervous about if she was going to do the test at our next visit. Because then I thought, well, if I'm nervous and I make mistakes, is she going to already assume I have Alzheimer?
Yeah, right.
So I started making lots of assumptions, which I do early on.
Well, it's this is more of a hypothesis. I think physician hesitancy is to have conversations like this, or is a complicated issue. I think one piece of it, they didn't really have a treatment option. So if I deliver a diagnosis, what's my option for this patient? Second, I think it's complicated by we have here in Arkansas specifically, we have limited access to diagnostic tools. So how do we diagnose? Right now, there's really only two ways to diagnose, and one of them is to get an amyloid PET scan, which we do not have access to here in Arkansas. So physicians have to refer those patients to Dallas or St. Louis or a place in Tennessee if they want to perform that specific test. Most commonly here in Little Rock and Central Arkansas and in the metros, we do know that geriatricians utilize a spinal tap where they can test spinal fluid for some of the hallmarks of the disease, like the amyloid plaque and the protein and the excessive, the presence of ApoE4, which is the Alzheimer's gene, right? So we know they use spinal fluid to test, and so. If a physician has concerns, how are they going to refer their patient to get the diagnostics to confirm it? And so there's another complication. What will change the game in terms of opening up access to diagnostics is when we're able to get to a point where we can test for the disease a third way, and that is by using a simple finger prick blood test, similar to the finger pricks that diabetes patients use to test their sugar levels. There is some developing research out of Sweden that has shown significant promise in terms of being able to detect the presence of amyloid plaque using the blood. And in one study we learned last week, physicians who actually had access to the blood test, their diagnosis was actually 80% more accurate than physicians who did not have access to the blood test. So if we can ever get to a point where we can test for it in the blood, that would open up access to diagnostics. It would change the game for us here because you don't have to rely on a very painful and intrusive way to pull spinal fluid out to test for it in the blood.
Why can't they just put you to sleep like they do when they're just doing a scan of your stomach? Because I've heard about that spinal. Yeah. Oh, that sounds horrible. But I have a question. So first, I have two questions. The first question is, are we going to get one of those PET scans anytime soon in Arkansas?
You would ask me a complicated question. I think it is something that we at the association are looking at very closely because we know that. Is it new,
a newish type of?
It is not, and
because PET scans they use for cancer.
Yeah, they use regular PET scans for multiple diseases and for multiple reasons in the clinical setting. The issue with the amyloid specific PET scan, it has to do with access to the dye that they put in you to perform the scan. And so we're still learning about some of the variables that are involved on how we obtain the dye. But the dye has a very short shelf life. And so you'd have to get it into the state and then use the dye within 6 hours. And then it has to be read by a neuroradiologist in a short amount of time. And so you have to have access to the dye. And that is one of the issues, one of the more expensive variables, I think, that we're facing. But we also realize that this is a challenge for health systems because there's a lot of upfront expense to bring that kind of technology to the state. And then they have to look at it from the business sense. Do I invest in this, and how many patients can I serve?
And then whether insurance will pay for it. Because I know
Correct.
that if insurance would work the way I think they should work, which is all of us, PET scans would be the best way for finding out if someone has cancer early on. Mm-hmm. But then you can't just use it if you find out you have a family history of cancer. There has to be a very specific. I don't know if that's changed, but insurance won't pay for it unless you are diagnosed with cancer.
And that's a very important point, because with the amyloid PET scan specifically, the payment models have not been there. So there's no way to reimburse the providers, because for years, the Centers for Medicare Services, which is who determines what Medicare pays for, right? They have only allowed for a patient to have one of these PET scans per lifetime. So they'd only pay for one per lifetime. 2 weeks ago, because of what we've seen in the evolution of research and treatments, and it was on the back end of the FDA approval for Leqembi, CMS had submitted a draft decision, so it still has to go through approval. But in that draft decision, they said something that gives us a lot of hope at the association, is that they will now pay for multiple scans for multiple amyloid PET scans. So it's not just one lifetime anymore. They've opened up access to that. Now, that's complex too, because it's, how they pay for that's going to be tricky. But at least they have made some steps to opening up access to amyloid PET by deciding they'll cover more than one. So that's encouraging. And when CMS makes a decision like that, private payers or like an insurance company like Blue Cross and Blue Shield, sometimes they're motivated to follow suit. And so it's something that we're monitoring, because if you don't have the payment model or the reimbursement model in place, then it makes it difficult for providers to take on, that expense and realize, so you have to have the payment model there. You have to have the insurance coverage.
Course, right.
And so, again, you kind of open up the door there, but I walked through it, but it is that this is kind of one angle that it's very complex, and there's so many different moving parts that.
Right. Well, let's hope those moving parts move faster, only because we know that the disease is increasing.
It is.
Quickly, especially with the boomers. So, but I say that because that's living in a perfect world of how things should work. And so we always know that we're going to be behind the 8 ball on important things, which makes it obviously frustrating. So today's podcast was really just to let you guys know about this drug, research. We got off on some other things that I know people are thinking about, early onset, or, not the fact that I think it would be early onset for me, but just because my mom and dad have it, or my dad had it, my mom has it, that, am I going to have it in my 70s? So those are things that, and I'm sure it's not just because both of my parents, even if one parent has it, you're still kind of like wondering, do I have that gene? Am I going to follow suit with mom or dad? So it is something that's on people's mind. First, difficult personally to have the discussion because it's frightening. Secondly, difficult to have the discussion because, let's say I scored poorly on the test. And, my mom is still living. And then all of a sudden I start to get fear and anxiety about the fact that, I can't even think about my own health at this point when it comes to Alzheimer's. I got to take care of her. So, there's, you talked about moving parts. There's so many different layers to, not just this disease. I'm sure other people, especially breast cancer, if it runs in the family, that's like you want to go get that test, but now you're scared of getting the results.
Right. And I think fear is a big motivator, not just in the disease space, but in life in general. We are often motivated by our fears. But if you look specifically in the cancer space, I can still remember a time where cancer diagnosis was a death sentence, and now they have advancements in treatments and are able to delay progression and attack the cancer cells. And so you see the evolution of treatments in other disease spaces, and you're hopeful that when we kind of look at the history in terms of our development, we're outpacing cancer in terms of the timing of when we got to a treatment. And so is there going to be more acceleration in our space? I imagine there will be a day where we take a multi-pronged approach to try to address Alzheimer's and dementia, where we look at lifestyle interventions. How can we reverse? Are there some things we can do to strengthen our brain health? I think that's going to be a piece of it. And then, of course, these early treatments. One of the other treatments we didn't mention was donanemab, and its phase 3 trials performed much better than Leqembi, even as much hope as Leqembi showed. Donanemab is another drug that's in the pipeline that we anticipate the FDA will grant approval to by the end of the year, but it's something we're watching pretty closely. And so there's a new drug that'll be on the market, and so we've gone from no treatments to as many as 2 in a very short time. So that's very exciting for us. And whenever you have those, then all these access issues, it opens up the opportunity for you to discuss some of these access issues. And then where our mind is how do we prepare the state for drug dissemination? How do we make sure we have the infrastructure, we have access to diagnostics, and we have the healthcare infrastructure to deliver the drugs now that we have them? And so those are some things that we are thinking about now at the association, but also with the advisory council. We're actually talking about some of these complicated issues and looking for some viable solutions to make sure that the state is prepared, because we want to make sure our seniors have equitable access to treatments when they come available.
So caregivers out there, that's one of the reasons I have David on, and usually twice a year. I would have you on a lot more too. But that
Let's go once a quarter.
Yeah, let's do, because it's important to sure, this podcast is trying to let caregivers know they're not alone, and that there's ways, there's tools, there's resources, there's ways you help yourself, and in a conversation with your loved ones, stuff like that. But it's important that you know that there are people like David and the rest of the crew at the Alzheimer's Association that are doing hard work on our behalf. And, if I hadn't had it, meaning if I hadn't had it in my family, I wouldn't have known. So that there was an association, that there was places like Alzheimer's Arkansas, that helps caregivers. So you should know that, there are organizations out there fighting the good fight on your behalf, and that's why you should support them, just like you would if you had a loved one with cancer and you start doing the cancer walk and worried about your own. Same thing here. And so just know, I've seen David in action. So when he meets these senators and et cetera, he doesn't waste any time. He knows exactly what he's talking about. He sits down with them, and it's obvious to them, because it's obvious to me as well, obviously, that you got it down, you communicate it well, and that I know that they respect what you're doing. So I just want to always thank you for what you're doing, and the way that you encourage me as a friend. So
I really appreciate that, and you are the why behind why I do what I do. Your stories and the stories of your audience are things that I carry with me when we are in a room. As we've shared before, it's more than a job. It's personal to me as well.
Right.
I've lost my grandmother, and now my dad with dual dementias that he's living with. So it's it is very personal to me. But the stories that we share, we make sure that we honor them, because we are fighting for people. And It's why I love what I do. It's definitely my motivator, though. I think about you daily when I'm doing my work. When we're doing things, I try to figure out how is this going to impact? Is this going to make things better? And we can't forget the people that we serve. That's why we're here. And we're here for you, regardless of what stage of the disease, and we want to serve everyone. If
Right.
people need support, you don't have to do this alone.
So for those out there, you can always call your local. I know that there are others listening they're not in Arkansas, but there's an association in your area, Alzheimer's Association in your town, in your state. So you can always call them to get some of this technical information that we've talked about today, and any information really. And then about Alzheimer's. But then again, we have here in Arkansas, Alzheimer's Arkansas, and their tagline is caring for the caregiver, and that is their role as well. So they may not handle the legislative and the technical stuff. They're there to love on the caregivers. And also, I bring them up because they have a grant for caregivers. Please take advantage. It was so easy. I did it last year. It is not a lengthy form, but if you need respite for a while, look into that grant. Every year so far, I guess starting last year, funds were dropped in there, and so hopefully, and David is also the association is part of that as well, getting that motivated and getting that done. So please take advantage of that, and always, caregiver, take care of your own health. Go to all your appointments. And because you are, you're their caregiver, you've got to be as sharp and as healthy as possible to care for them.
Yeah, and we appreciate what Alzheimer's Arkansas does in the space. We also, component of our work is to provide care and support services for all those who are impacted. And regardless of where you're listening, we do have a national hotline that you can call 24 hours a day, 7 days a week. Doesn't matter what day it is, we are always open, and that is 1-800-272-3900. And you will talk to a master's level clinician who can answer questions, refer you back to the local chapter in your state, and you can receive access to services that you need, or we can refer you out to other providers like the grant. But the grant is such an important thing for Arkansas. We reported on it yesterday at our advisory council meeting, and that report highlighted some of the reach that the grant had in its first year. It has been funded for a second year, and funding is now available. But there's some conversations happening on how do we make that program more accessible to caregivers, how do we make it easier for caregivers, and then how do we actually expand our reach with the program. So There was a lot of excitement around that, and so we are very appreciative of the accelerated approach Arkansas has taken over the last few years to engage on this issue. We have a lot of work to do, but we are encouraged by what we've seen and the level of support that we see by our decision makers. But yeah, I went on a little
that's great.
chased a little
And
rabbit
don't
there.
forget too, caregivers. There are classes and there are support groups. I took advantage of them early on because I didn't know anything about the disease, and I felt alone, and I was really, really scared. And as in any support group, that's what they're there for. You're going to hear from people that are dealing with it and have a loved one, and they're going to I got great tools, I got great everything just by them sharing their experience. Anyway, thank you, David, very much for coming.
Thanks for having me.